Thank you so much to the organizers of the NeuroLily conference for inviting me to speak with you today on biomarkers in subarachnoid hemorrhage. It's my honor to join the panel today talking about what we can learn from some new advances in biomarkers. My name is Nerissa. I'm professor of neurology at University of California, San Francisco. And I'll begin my talk with some disclosures and some slides that I have thankfully shared with my colleague, Dr. Sherry Cho. So to start with an overview about biomarkers in general, there are many types of biomarkers, from molecular, histological, radiographic, and physiological biomarkers. But really, our U.S. Federal Drug Administration thinks about biomarker categories in more functional ways. Are they used for prediction, response, monitoring, safety, diagnosis, predicting risk and susceptibility, and more importantly, for prognosis? We can learn a lot from our cancer colleagues in terms of blood biomarkers, which will be the focus of our time today. There are many, many biomarkers that would take more than our allotted time to discuss. But focusing on serum biomarkers and blood biomarkers, you can see that when we take a blood sample from a patient, we can use many components from the serum to the plasma, to the DNA, the mRNA, and in recent times, microRNA. And we'll touch on a few examples of this during our talk today. So why do we actually think about biomarkers in a disease of subarachnoid hemorrhage? We know this is one of the most devastating consequences of a ruptured aneurysm in the body. We've learned that it's a combination of injury in the early phase. When the aneurysm ruptures, it sets off a cascade of multiple injury models, including the brain itself, as well as to systemic complications. And there's also a delayed phase of injury, which happens often in about 2 to 3 days after the initial insult. And because of this, it's become one of the most complicated neurological conditions that we manage today in our neurocritical care units. Can we use blood biomarkers in subarachnoid hemorrhage? Is there any utility at all? There are definitely unique challenges with a complex neurological and systemic disease, especially in the brain with the existence of the blood-brain barrier. Can serum biomarkers in the blood really reflect an injury that's going on in the brain? The disease process itself, as we talked about, is quite dynamic from the early injury model all the way through to the course of the injury, and it rapidly changes over time. Can a static glimpse at one time point be sufficient to really tell us and inform us about the disease itself? Individually, patients are not all the same. This is a very heterogeneous patient population, and they may present differently with the same disease phenotype over time. And how useful are these blood biomarkers for our day-to-day management? We know that in the ICU environment, we often have to make critical decisions in the management of these patients in a very time-sensitive way. So any biomarker that we use in the ICU needs to have results that come fast enough to be able to meet these time windows of our critical decision-making. I like this review from Dr. Locke McDonald and group, although it's now from 2014, it really frames the disease of acute subarachnoid hemorrhage as a very systemic neurologic and response. Not only is it causing mechanical injury and tissue injury to the brain, it sets off a global cascade of ischemia and early brain injury. There's many cellular changes that happen that also lead to the systemic complications that are very, very common in this disease. And despite the blood-brain barrier issues, often in the injury model, the blood-brain barrier is itself disrupted. Why does it matter? Don't we take care of subarachnoid hemorrhages very well already? Although we've had advances in surgical and endovascular treatment over time that have improved the mortality of this disease in all the sectors, we still struggle to get the best outcomes for our patients. It remains one of the most highly morbid and mortal diseases that we face in our patient population. Out-of-hospital mortality is still quite high, but even in those who survive to hospitalization, about a third of them remain dependent and unable to return to their same quality of life. And if you include high-order cognitive issues and mental health issues, there are even more impaired patients in this otherwise good outcome group. So what do we use now? We often will manage the patients based on their initial clinical presentation. And so whether you use the Hunt-Hess score or the World Federation of Neurological Surgeons score, the severity of the initial clinical presentation often drives how we manage these patients and their overall outcome. We do have radiologic markers with the initial CT scan that helps us predict the degree of injury based on the amount of blood from the initial aneurysm rupture. And we have other imaging modalities that help us identify the source of bleeding and treatment of complications such as hydrocephalus. But one of the more elusive things with this disease is this delayed phase of complications. As we said, we've done well with treating hydrocephalus and rebleeding with standard clinical and radiographic markers, but the vasospasm and delayed ischemia and delayed injury that keeps these patients in the ICU up to 2 weeks in duration remains very elusive to even the most seasoned of clinicians. There's also a host of medical complications. And as we said, this is really a systemic disease, almost akin to the sepsis of the brain that many of our medical ICU colleagues manage. We often can see severe pulmonary complications to the point of ARDS. We can see every kind of arrhythmia, and we've seen significant cardiac ischemia as well. So biomarkers are not new. We already have many candidate biomarkers that we share with other severe injury models such as TBI and stroke. And there are numerous articles looking at some of these candidate biomarkers. And this is just one from Neurocritical Care from Dr. Cho and colleagues. But when we think about these delayed complications in subarachnoid hemorrhage, part of our issue is that it's very hard for us at the bedside to distinguish between angiographic vascular issues, delayed ischemia and infarct, and these delayed brain injuries that we're starting to understand that are not ischemia at all and may be related to the inflammatory response of the brain. We do have lots of different factors that have informed us over the years, and new tools that we use at the bedside, both radiographic, our clinical exams, imaging, and some electrophysiology and microdialysis type of invasive monitors. And yet all of these things still leave us at a crossing point as clinicians when we still have difficulty predicting which patients are going to go on to the most severe complications and which ones go on to have the worst outcomes. So when we think about one of the most elusive of these complications, delayed cerebral ischemia and with or without angiographic vasospasm remains one of the things that is well studied, yet remains the most challenging and leads to the highest degree of morbidity and mortality after subarachnoid hemorrhage. And as you can see from the same review, that it's a combination of many factors. Before, we used to think about the vascular spasm, what we could actually see in radiographic studies, but we've learned that it's beyond that there's probably more things going on in the inflammatory cascade and the local microenvironment that probably leads to a lot of the systemic complications and other delayed neurological complications. We know from the clinical that there are certain things that seem to help us predict, and those are typically related to severity of injury, amount of blood, and location and other risk factors. But we also have learned that some common biomarkers, so not every biomarker has to be sophisticated assays or very, very new technology. One of the earliest things we looked at in our group back in 2011 was a serum biomarker of brain natriuretic factor. And we found that elevated BNP was associated with vasospasm independent cerebral infarction after subarachnoid hemorrhage. So there are some common biomarkers, and similarly looking at methods of inflammation, looking at initial white cell counts. These are some of the things you'll start to see as common serum biomarkers that can be done in any setting, in any environment. But we know this is more sophisticated than a single pathway disease. And so as we start to really look underneath all of this, there are many cascades of things turned on by blood released from an aneurysm rupture. And this is one of the things that's been challenging when we look at single cell, single pathway markers of disease. So we looked at genetic biomarkers as one of the ways we can maybe account for some of the individual patient variability. Initially, the studies mostly were candidate genes that looked at single pathways in isolation. And as the technology has improved and ability to do lower cost genome-wide association analyses, we can now look at multiple things not limited to a single pathway. There are limitations, however, in terms of replicating findings of these large-scale studies that are often part of multi-center trials. There's a lot of limitations of the large sample sizes required and the need to account for population differences around different race ethnicities and things of that sort. But there have been lots and lots of studies on genetic polymorphisms associated with delayed ischemia after subarachnoid hemorrhage. And these are just a few examples. One of the studies that we did very early on in 2008 was looking at the association of nitric oxide polymorphisms and the angiographic component of vasospasm. And we can see here that, it was very much the age and gender as well as the enos polymorphisms that predicted angiographic spasm in this patient population. We also started to look at the genome-wide association studies in our patient population, and this is a typical way that these are presented in what we call a Manhattan plot. And you can look for things that cross a log threshold that show potential association with the outcome of interest, in this case, vasospasm. And when we looked at logistic regression of the top single nucleotide polymorphisms that came out of this Manhattan plot analysis genome-wide, there were several genes that were identified. And like I said, this allows us to look at multiple pathways at a time. And the overall results of this initial look was that there were 11 single nucleotide polymorphisms and that showed some significance. Some of them were in areas of interest in terms of functional parts of the genome. And then looking at what these might relate to in terms of areas that could be of interest in spasm versus non-spasm patients. And so we may have identified a potential role in this very preliminary analysis in Wnt signaling and TGF-beta signaling in this pathophysiology. But yet again, the limitation is being able to replicate these studies in an independent population and making sure we can correlate them with other outcomes that we know are important besides angiographic vasospasm. The next area that I'll touch upon is the area of omics. So this has really exploded in recent times due to a lot of the technology that's allowed this to be done in much broader arrays and with the ability to analyze big data. The development of microarrays has really made it possible to look at all the RNAs expressed in any tissue, including those derived from brain and blood. Initially, there are a lot of technical aspects of these early assays, but these are getting better and better over time. The same issue with any kind of biomarker sampling is when we collect the tissue or blood sample, does it really reflect the overall course of the disease or just that one moment in time? Is this sampling sensitive and specific enough to help us make clinical decision making? And it does lead to an enormous amount of data, as I'll explain in the coming slides. Our study here of genome expression in human vasospasm was a small study just to sort of look at proof of principle. And we looked at a very common, typical subarachnoid hemorrhage patient population. And at the end, we found at the whole transcript level, there were 210 genes identified that were differentially regulated between those patients found to have angiographic spasm and those without. When we get to the exon level, There were even more exons that were differentially regulated, and some of these were in signaling pathways that were quite unique to genes related to things that make sense: immune response signaling, cardiovascular signaling, neurological signaling, and apoptosis and cell death. So this is what a typical cluster analysis looks like from when we do these types of mRNA expression arrays. And you can see that, these are heat maps that really show a way to segregate different genes and exons that are variably expressed in the two different clinical patient populations. We then are able to do a principal component analysis and see if we can discriminate between our clinical area of interest, in this case, vasospasm. And we can see that the gene profiling really does allow us to separate the two patient populations quite well. We then can look and see if any of these genes have any functional utility, and whether or not these are in signaling pathways of interest that make sense with known as well as new mechanisms that may be novel to this disease process. And this is just the type of output you get with pathway analysis and some of the diagrams that you get looking at what's upregulated in green and downregulated in red. And this happens to be the nitric oxide signaling pathway. And this is yet another one in a microphage pathway as well. What's more exciting are actually newer techniques in microRNA, and this is really kind of the area that is rapidly expanding in terms of biomarker studies. And this is really another way we can look at other types of tissue-specific and cell-specific markers in the bloodstream. This is a review paper that I pulled up as an example of this, and really microRNAs are really the cutting edge of where some of this new technology is coming from. And as you can see here, you can actually take whether you use CSF or plasma samples and separate out with quite good predictive value a series of different panels of microRNAs that can really show multiple physiologic pathways. So we can move from a single output, single kind of pathway to more multiple interrelated pathways and see if that can help predict our clinical area of interest. More importantly, I think, despite the overall look at different things that can help us manage patients, I think of most keen clinical interest is overall outcome. And biomarkers and the predictors of outcome of subarachnoid hemorrhage have been going on for quite some time. There's a nice review here by Dr. Simard's group that really looked at some of the things that are common to other brain injury. So you'll see neuron and astrocyte-specific markers that are seen in many tissue models, from cardiac arrest to trauma to stroke. They looked at correlations with S100 beta, neuron-specific enolase, GFAP, and ApoE as potential markers of poor outcome. Not surprisingly, there were also lots of inflammatory biomarkers and C-reactive protein. And I think the ones of most keen interest in cytokines have been TNF-alpha and IL-6. We know this is a systemic inflammatory response that's characterized by huge catecholamine surges and other hypermetabolism states. And so there's also been markers of that. When we look at the extracellular matrix and more deep molecular markers, not surprising, there's some common markers in MMP9, the ICAMs and VCAMs, and selectin genes and proteins. Because it's a vascular disease and we think that there's activation of the clotting cascade, there's also been many identified products and biomarkers in the realm of vasculature and clotting cascade, some of which are mentioned here. So I know this is just a quick survey of the realm of what's possible in serum biomarkers and blood biomarkers in subarachnoid hemorrhage. Some may argue that perhaps blood is not the best tissue to sample because CSF may be actually closer to the tissue injury itself. And certainly similar studies have been done in CSF as well. But why do we need all of this? It's a lot of data, and has it really changed the way we actually manage these patients? I think the field is still expanding and growing, and we still need to figure out how to integrate this information in our standard practice of these patients. We are pretty good at diagnosing aneurysms that rupture based on our clinical and radiographic studies, and we can tell if there's subarachnoid blood on a CT scan and have imaging to look for the site of aneurysm rupture. But I think the holy grail of questions that biomarkers are still being looked at today is when you have an unruptured aneurysm, and how can we tell which of those patients are going to go on to have a high risk of rupture and those which will stay quiet and benign for the course of their lifetime. And so that is still an elusive question that many people are working on. When we actually find the source of hemorrhage and treat and repair, we often can prevent the most serious consequence of re-rupture and re-bleeding. And this has really improved mortality in this disease over time. Where we really struggle is in this delayed phase, and vasospasm and delayed ischemia are just one of the most common areas where we struggle so much to, despite being aggressively treating the spasm that's seen on angiogram, we still are left with very large infarct areas, often in places completely opposite from the vascular changes that are seen in radiographic studies. And so this is an area where biomarkers are really much needed and can really help inform and give us a chance to predict those patients rather than react to patients who are already in the throes of their severe injury. And this can really improve outcomes in our patients. And lastly, I think our patients and families care the most about long-term outcome. How can we tell them which of the patients are going to go on to have a full or near complete recovery versus those who may continue to live their lives in a dependent state? And this is really quite a challenge of neuroprognostication, especially in a complex disease like subarachnoid hemorrhage, where we have so much heterogeneity of outcome and otherwise healthy patient population, because this often affects very young patients. And so I think this is really a key area where biomarkers could be really helpful in allowing us to be better and more precise in our prediction of outcome. So just to close out our talk today, I wanted to really talk about biomarkers in a broad sense. You know, we are at a really incredible precipice in development of novel biomarkers and the technologies to really perform these in real time and make them clinically useful to practitioners in the ICU. We still don't know everything that we need to know to manage this disease. And so the biomarkers may not be as useful clinically yet, but they can help us in hypothesis generating to improve our understanding of these complex mechanisms. And now that we can really think about a systems focus versus single molecular targets, this might really be able for us to think about a whole system of injury versus singular molecular targets. This integrated approach where we can use genetic polymorphisms, correlate them with the proteomics, metabolomics, pharmacogenomics. I think this is really how we can integrate all of these is kind of the wave of the future. And then with these newer protein and tissue expression assays with microRNA, I think there's going to be a lot more in this field to come. We still need to identify better targets for intervention and drug development. We still have very limited medical management therapies for secondary brain insults, such as delayed ischemia, and even the medical complications that are so common in this disorder. And then lastly, the importance of outcome prediction and refining our models to improve our prognostication for our patients and their families. So I'll end with that, and we'll be available in the Q&A in the live to take your questions. Thank you once again for allowing me to participate in this wonderful conference, coming to you from California and the Bay Area, and look forward to seeing you all at the conference soon. Thank you.